multiple colonic injuries for grading and universal management plan. And I have nothing to disclose. Wounds of the colon resulting from penetrating or blunt abdominal trauma are commonly encountered in civilian and war circumstances. Prior to the World War II, this type of injuries was associated with significant mortality and morbidity. There are various choices for colon injuries surgical repair, but they can be grouped into categories. Primary repair is either the direct suturing repair or resection and anastomosis, and diversion or colostomy. Surgeon's decision for one surgical procedure or another is influenced by a vast area. Here a diagram showing the severe effect of the high velocity projectiles causing extensive damage to the soft tissue via permanent cavity. It is the primary tract of injury, and the temporary cavity caused by the negative wave of pressure, which causes much wider and more extensive injury than the primary. Here, a diagram showing that the temporary cavity is more extensive and wider than the primary cavity. Many classification systems of colon injuries have been established to facilitate the clinical research and have a uniform system of reference. The Penetrating Abdominal Trauma Index was published in 1981 and was designed to assess the degree of injury to the all abdominal organs and to predict the postoperative complications. Although mentioned in some research, yet multiple colonic injuries were not included as a separate category in any of the classification systems. The objective of our study is to demonstrate the presence of multiple injuries of the colon due to high velocity capsule wounds and shotgun wounds as a definite clinical and operative entity and to evaluate its prevalence in clinical practice. During the war activities for a 6 months period in southern part of Saudi Arabia from October 2016 to March 2017, 23 wounded patients who sustained injury of the colon were included. All patients were soldiers and they are managed according to the ATLS guidelines. CT abdomen with contrast was done for hemodynamically stable patients, while unstable patients were sent directly to the OR. Here a diagram showing a picture showing the CT of the abdomen with the bullet tract or primary damage, and the main value of the CT in gunshot abdomen is to evaluate the injuries to the retroperitoneal structures, namely the kidney and ureter. Laparotomy was done for all patients via midline abdominal incision. Full exploration of the abdominal contents was done. Hemostasis with control of bleeding sources was done as a first priority. Injuries of the colon were graded according to the American Association of Surgical Trauma and managed. For grade 1 and 2, primary repair was done on both sides, while for grade 3 and 4, right hemicolectomy was done on the right side, while on the left side, colostomy was done, a form of heart-valve procedure, and we could identify another type of injuries which we had to manage in the 81. The presence of multiple colon injuries due to shotgun injuries and high velocity. Here a picture showing operative picture showing type 4 colonic injuries with loss complete resection of the colon and maybe even grade 5. The decision was difficult in 4 cases who showed multiple injuries to the colon. Either to do primary repair of such multiple injuries, done already in 2 cases with lower grades of injury, or a resection anastomosis. Hartmann procedure was done for higher grades of injury, done in the other 2 cases with higher grades injuries. Here a diagram showing the American Association of Surgeons of Trauma grading scale for colon injuries, with grade 1 including the hematoma with the superficial laceration with no penetration, with grade 2 less than 50% of the circumference was injured, grade 3 more than 50% of the circumference, grade 4 with complete transection of the colon, and the grade 5 complete transection with loss of a segment and or devascularization of the colon. Results of our study. Our study included 23 patients presenting with abdominal gunshot injuries with varying degrees of hemodynamic stability. Patients fell in the age range of 19 to 30 years with a mean age of 26.6 plus minus 4.4 years. An expected figure because all of them were young soldiers. All patients included in the study. The most common part of the colon involved in our study was the left colon in 60.9%, followed by the right colon in 17.4%, the transverse colon 15%, and the cecum 8.6%. Here, the most commonly injured part in our study was the left colon in 60.9%. Colon injuries were graded according to the American Association of Surgeons of Trauma, with grade 1 found in 1 patient, grade 2 to 6 found in 6 patients, to 26%, grade 3 in 6 patients, and grade 4 in other 6 patients, while 4 patients sustained multiple perforations of the colon in a percentage of 17.7%, which is a significant percentage. The multiple injuries were found in 17.7%. This is represented by neurocolor, with gunshot wounds on the abdomen. Of 14 patients with primary repair, 2 cases showed post-operative leak and needed redo surgery with diversion, with a success rate of 85.7% and a failure rate of 14.3%, while in cases with colostomy, no immediate post-operative complications were detected. All colostomy patients were readmitted 6 weeks later for closure of colostomy. Colon is involved in approximately 27% of trauma cases undergoing laparotomy for gunshot wounds, with a transverse colon being the segment most commonly frequent. Many classification systems of colon injuries have been established to facilitate clinical research and have a uniform system of reference. Flint et al. In 1981 developed the Flint grading scale for colon trauma, with grade 1 injuries including the isolated injuries with minimal contamination, minimal delay in operation, and minimal shock. Grade 2 injuries are true and true perforations or laceration with moderate contamination, and the grade 3 injuries have severe soft tissue loss with devascularization, heavy contamination, and can have a profound shock. The American Association of Surgery of Trauma colon injury scale was established in 1990. Injuries are classified as grade 1 to 5, with grade 1 injuries being partial thickness injuries without perforation, and grade 5 being transection of the colon with segmental tissue loss or a devascularized segment of the colon as grade 5. Destructive and non-destructive colon injuries are terms used in the literature based on the 2 former classification schemes. The wide variation in the results of surgical treatment of colon injuries is probably due to the presence of other types of injuries that are not included in the present classification. Multiple colonic injuries were not mentioned as a definite entity, although they were reported in some literature. Fuzi et al. In 2001 mentioned the presence of multiple injuries in the colon, and they were managed them on individual basis. In our study, we found that in 4 patients there were multiple injuries of the colon and a percentage of 17.7%, which is a significant percentage. 2 cases were treated with primary repair, while the other 2 patients were managed with diversion. In conclusion, the wide variation in the results of colonic injury treatment in many studies may be attributed to the absence of some clinically evident types or patterns of injuries that are not mentioned in the present classification systems. These patterns of injuries need to be addressed with clear guidelines for adequate management. Thank you very much.